Welcome to The Explainer. Today, we are taking a close look at one of the most intense, high-stakes biological realities in human medicine. We're going to literally strip away the medical jargon to break down the anatomy of an emergency, the myocardial infarction. We'll see exactly what goes wrong when the heart's very own life support system suddenly and without warning fails. It's kind of the ultimate biological paradox, isn't it? Like, how does a condition that takes decades to develop just strike in a single terrifying instant? This is the core question we really need to answer today. Because, understanding the precise mechanics of this transition, going from a completely silent background issue into an acute crisis, well, that isn't just fascinating, it's absolutely vital knowledge. Okay, to get there, let's ground ourselves in the exact medical reality. A myocardial infarction, or MI, isn't just your generic attack. The absolutely crucial word here is infarction, which literally means tissue death. When one or more of the coronary arteries that supply the heart muscle gets severely reduced or totally blocked, those cells are violently starved of oxygen-rich blood. So at its core, an MI is a localized crisis of severe oxygen starvation. So, Section 1, the perfect storm inside. Causes and triggers. This perfect storm, it actually begins with a super silent condition called atherosclerosis. That's a really slow, progressive buildup of plaque on the inner walls of your arteries over decades. So step 1 is that long-term accumulation of cholesterol, fats, and inflammatory cells. Then step 2 is the sudden, violent trigger, a plaque rupture or erosion. And step 3 is the catastrophic result of that trigger, clot formation. Just like that, the artery is completely blocked. Now, statistically speaking, plaque rupture is the overwhelming primary culprit here, driving roughly 65% of these events. Plaque erosion accounts for about a quarter, and this is a really critical distinction. It shows us that the majority of heart attacks aren't just, pipes slowly clogging up until they close completely. They are sudden structural failures of the plaque itself. Let's actually put those two primary mechanics side by side. With a plaque rupture, picture a thin, highly inflamed fibrous cap covering a soft lipid core, and it just tears wide open. The body's repair system violently overreacts to this and forms a massive clot. It's highly inflammatory and often leads to the most severe type of attacks, known as STEMIs, which we'll define in just a sec. Plaque erosion, on the flip side, is when the smooth inner lining of the artery just kind of wears away. It's typically associated with less inflammation, sure, but it often sneaks up on younger patients and smokers. But we definitely have to acknowledge the outliers too. About 5 to 15% of cases fall into an other category. We're talking about severe coronary artery spasms, a spontaneous tear in the artery wall, which is known as SCOD, an embolism traveling from somewhere else, or even protruding calcium nodules that literally shred the vessel lining. These are rare for sure, but they're a stark reminder that even patients without a single traditional risk factor can suffer a sudden catastrophic blockage. So, the trigger is pulled, the clot forms, and the oxygen is cut off. How long does the heart muscle actually have? 20 minutes. Yep, just 20 to 30 minutes. That is the incredibly short window of time you have before permanent heart muscle damage begins to set in. The clock starts ticking the very second that artery is blocked. Moving right along to Section 2, decoding the heart signals, the investigation. Because that clock is ticking so unbelievably fast, the moment a patient hits the ER, the medical team has to act like rapid response detectives, and they rely on two crucial clues. First up, the electrocardiogram, or ECG, which maps out the heart's electrical activity. Second, blood tests, looking for specific proteins called troponins. You see, when heart muscle cells are dying, they spill these troponins directly into the bloodstream. It's basically the biological smoking gun, confirming the injury. When they are decoding that ECG, doctors are looking for a really stark contrast, a STEMI versus an NSTEMI. A STEMI, which stands for ST elevation myocardial infarction, indicates a complete prolonged blockage. It is a full-thickness, extreme emergency. An NSTEMI, however, shows no classic ST elevation, meaning the blockage is likely partial or temporary. Now, both are definitely serious, but the STEMI, that is the ultimate red alert. Beyond what's flashing on the monitor, doctors also classify the underlying mechanics. Type 1 MI is what we usually picture in our heads, a primary clot from an acute event, like that plaque rupture we talked about. But type 2 MI is entirely different. It's an oxygen supply and demand mismatch. Say a patient has severe anemia, off-the-charts blood pressure, or a dangerously rapid heart rhythm. The heart demands way more oxygen than the blood can physically supply. And that causes tissue death even without a primary clot. Which brings us to Section 3, The rescue. The race against time. Diagnosis made? Boom. The investigation immediately becomes a rescue operation. And these interventions begin before the patient even reaches the hospital doors. Calling EMS is obviously step one, but step two is absolutely crucial. Chewing 325 milligrams of aspirin. Actually chewing it gets those antiplatelet effects into the bloodstream immediately. Paramedics will also administer oxygen and use morphine to manage the severe pain, which helps reduce the cardiac workload. Once the patient is stabilized, the really heavy-hitting medical therapy begins. Doctors use a dual antiplatelet approach, combining that aspirin with a specialized medication called a P2Y12 inhibitor to stop the platelets from clumping together. They also use anticoagulants like heparin to halt the clotting cascade entirely, deploy high-intensity statins to brutally lower cholesterol and stabilize the plaque, and manage ongoing strain with beta blockers. It's a full-on chemical assault against the blockage. But if we're dealing with a STEMI patient, that full-thickness emergency we talked about, medications alone just aren't enough. The magic number here is 90. 90 minutes. That is the absolute critical golden window. From the exact moment the patient arrives at the hospital, the goal is to physically open that blocked artery within 90 minutes. So, how do they do it? Usually through primary PCI, percutaneous coronary intervention. A surgeon threads a catheter, often right through the wrist to reduce bleeding, inflates a tiny balloon, and places a stent to prop the artery open. It's an incredible procedure, but if a PCI isn't available within 120 minutes, they have to pivot to chemical alternatives, thrombolytics, or clot busters. These are really powerful intravenous drugs designed to just dissolve the blockage. Now, if the patient has an NSTEMI, the partial blockage, the timeline shifts just slightly. High-risk NSTEMI patients typically undergo angiography within 24 hours. But if they are clinically stable, doctors might actually manage them with those heavy-hitting medical therapies we discussed for up to 72 hours before deciding if a stent is really needed. That partial blockage buys the medical team a slightly extended, manageable window. But honestly, regardless of the specific type of MI, there is one core medical mantra that drives literally every single decision in the cardiac ward. Time is muscle. It summarizes the brutal biological reality we started with. Every single passing minute that an artery is occluded equals irreversible tissue loss. You simply cannot get that muscle back once it's gone. We've seen how a lifetime of silent buildup can violently erupt into an emergency, and we've seen the incredible medical engineering used to fight it. But you know what? The most advanced stent in the world is completely useless if you stay at home ignoring chest pain. Knowing these treatments are exponentially more effective in that very first hour, are you prepared to recognize the symptoms and act immediately? Seriously, think about it. Thanks for joining me on The Explainer.